I'm Dr. Ken Landau. This is Well Now Doctor. Thank you for joining us. We're going to be discussing atrial fibrillation. Now, we've already said that atrial fibrillation is an extraordinarily common condition. It's an abnormality of the heartbeat. We call it a cardiac arrhythmia. It's as common as all of the other heartbeat irregularities all put together. We know that atrial fibrillation probably affects as many as 2.5 to 5 million people in the United States, a number that's expected to increase over the next 20 or 30 years to maybe as many as 15 million. We know people who have atrial fibrillation are at increased risk for a variety of health-related problems, especially because of slow-moving blood inside the heart is allowed to clot. If it clots inside the heart and then breaks free, then you can develop a stroke. And we know that stroke is an extraordinarily common problem associated with atrial fibrillation. We know it's also associated with a variety of other cardiovascular problems as well. We know that if you look at age is a significant predisposing cause for atrial fibrillation. So it's a very uncommon condition in children, unless there's some other structural heart abnormality. We know that as a person grows older, the incidence increases considerably, so that if we're talking about people who are less than age 50, the incidence is probably less than 0.5%. On the other hand, if we talk about people 60 to 70 years old, well, it's probably somewhere around 5%. And if we look at people who are over age 80, the incidence is probably somewhere between 9 and 15%. And some people say as we grow older and older, the incidence may be as high as 50% in those people over age 80. Well, that's if they have associated cardiovascular problems. It seems that people who have heart-related disease increase their likelihood of developing atrial fibrillation. So people who've had a heart attack or people who've had some kind of problem, for instance, maybe congestive heart failure, those people are at increased incidence. But so too are people who are relatively young, who exercise too much. So we know that it's not an uncommon problem associated with overuse of the cardiovascular system as far as exercise is concerned, or people who have high thyroid levels, hyperthyroidism, people who have difficulty controlling how much alcohol they consume. Those people seem to have a higher incidence of atrial fibrillation, and so too are people who use certain kind of illicit drugs. Drugs maybe in the cocaine family, or maybe even marijuana can increase the incidence of atrial fibrillation. Now, we know there are a variety of suggested causes. We know that some people think that the cause may be related to an ectopic focus, somewhere other than the normal area where electricity is generated inside the heart, inside the right portion of the atria. Remember, we talked about the atria and the ventricles. There are two atria, one on the right side, one on the left side. And then there are two ventricles, one on the right side, one on the left side. We know that there's a junction between the two, the upper chambers, the atria, and the lower chambers, the ventricles. This is the atrioventricular junction, and that's where the impulse goes. The impulse goes from high in the right atrium under normal circumstances down through the atria that contract. The impulse then goes to the atrioventricular junction, spreads out to the ventricles, and then we have a nice orderly contraction. In atrial fibrillation, we do not have that normal contraction. We think that maybe instead of the impulse coming from the sinoatrial node up in the right atrium, it comes from somewhere else. Maybe it's caused by abnormal flux of ions, sodium or potassium or calcium inside and outside of the cell. Maybe it's caused by an abnormality of nerve controlling in the heart, too much adrenaline or substances like that, or too much activity of what we call the vagal nerve. Maybe it has to do with impulses that start in one place and just go around like a circus, around and around and around inside the atrium. They never stop. No way to get off, kind of like a merry-go-round. Well, there are a variety of other causes, but we know that overall, atrial fibrillation seems to be associated with increased frequency as the heart becomes abnormal, so people who have some kind of heart disease. However, early on in relatively younger people, say people less than age 60, who develop atrial fibrillation, it used to be known as lone atrial fibrillation, L-O-N-E. Means it happened by itself. It didn't have any other kind of reason. originally it was thought that maybe somewhere between 20 and 50% of all people with early onset atrial fibrillation had this lone atrial fibrillation variety. Now we think it's very small. In fact, some people say that there's no such thing. If we look hard enough, we will find some sort of cardiac abnormality in all of these people. Well, on the other hand, people who have lone atrial fibrillation, people who are less than 60 years old, who don't have any demonstrable abnormalities. So on clinical examination, we don't find any problem. We do a chest x-ray and find that it's relatively normal, nothing abnormal that would suggest that there's heart disease. We do an electrocardiogram, maybe even a stress test. No problem. There isn't any kind of disease of the heart that's found. So we do some more tests. We do an echocardiogram, sort of an ultrasound examination of the heart. No problem. So basically, these people without history of cardiovascular disease have a good prognosis. Their atrial fibrillation comes and goes, and comes and goes. Sometimes they're aware of it, sometimes they're not aware of it. Remember, atrial fibrillation, a very rapid upper heart rate, doesn't necessarily mean that the bottom part of the heart, the ventricle, is going to contract terribly abnormally. So if we look at our pulse, if you check your pulse rate probably is going somewhere between 60 and 80, 60 and 90 beats a minute. It's considered normal if it's up to 100 beats a minute. Well, in people who have atrial fibrillation, where we have so many impulses coming out of the top part of the heart, more than 300 a minute, well, if we check the pulse in those people, it might be 120, 130, 140. In some people especially who are very old, well, those people, because of disease at that junction that we talked about a moment ago, the atrioventricular junction, the area where the impulses have to go after they're generated in the top part of the heart, whether normally or abnormally, to get to the bottom to tell the ventricles to contract, well, if that junction, if the AV junction doesn't work right, doesn't allow the impulses in, the heart rate might be basically normal, might be less than 100. So we know that's not the case in these people who have lone atrial fibrillation. They're otherwise apparently normal. There's no heart-related disease at all. But when we do very careful evaluation, so we take a group of people with lone atrial fibrillation, we find a significant number of them have some sort of infiltration in the heart with eosinophils and lymphocytes. They, in other words, have inflammation of the heart. And we're going to talk about inflammation again and again and again, because it seems that the inflammatory condition seems to stimulate the likelihood of atrial fibrillation. So we know some of the people who have lone atrial fibrillation have myocarditis, even though they have no symptoms. They do have an inflammation of the heart. And in some people, there's a diffuse cardiomyopathy. The heart cells just don't seem to function normally, especially those cells in the ventricles. And we know that a significant number of other people, basically rounding out the entire group, have some sort of diffuse fibrosis, diffuse scar tissue that develops. Now, if you have scar tissue in the heart, remember that those impulses trying to find the normal channels may well just go around and around and around. So we know that early on in the course, atrial fibrillation tends to occur by itself, oftentimes associated with no other cardiac abnormality, seems to come and go, seems to not cause many symptoms. Maybe in some people it causes a very rapid heart rate for a short period of time. And by the time they get to the doctor can't even find that there's any abnormality because this is just an intermittent condition. It comes and it goes. It can disappear within less than 24 hours, often just several hours. Well, we know that as time goes on, we tend to develop a different kind of atrial fibrillation. And with each different manifestation of atrial fibrillation, or each different category, there's a little bit more heart disease. So now we get into a condition known as paroxysmal atrial fibrillation. Paroxysmal, comes and goes, sort of like it does in lone atrial fibrillation. Oftentimes comes and goes. It's more often in young people who otherwise have a normal heart. Actually, by definition, people with paroxysmal atrial fibrillation seem to revert back to normal within less than 7 days. And as I said, oftentimes within 24 hours. In fact, it's very difficult to make the diagnosis, even if we do the 24-hour Holter monitor that seems to be so popular. We put on a device and you wear it at home for 24 hours. It might not have any recurrence. might have to have a 30-day monitor. Some people, even a longer monitor needs to be implanted inside the chest so that we can find that these people are indeed suffering from paroxysmal atrial fibrillation. Now, over a period of time, over a period of years, with the accumulation of your high blood pressure, accumulation of maybe some sedentary activities, maybe you're cigarette smoking, maybe too much alcohol, maybe some cardiovascular disease associated with atherosclerosis, hardening of the arteries, well, then you can develop the next stage. And the symptoms are exactly the same in one stage versus another. It's just how long the problem lasts. So now we have a condition known as persistent atrial fibrillation. Remember we said in paroxysmal atrial fibrillation, oftentimes it's not going to even last for 24 hours. Now in persistent disease, it tends to last for somewhat longer. And in fact, we define the condition as atrial fibrillation lasting longer than 7 days, or atrial fibrillation that just causes so many symptoms that you have to have some sort of medical therapy, either cardioversion that we can do with drugs or by defibrillating an individual with some electricity. And sometimes the symptoms just don't cause all that much problem. Sometimes, as we said before, people don't even know that they have the problem. So they just have an abnormal heart rate. Maybe they think they have indigestion. Maybe they think that they're just nervous about something. Maybe they think that, well, geez, I'm having trouble with the IRS, I'm having trouble with the spouse, I'm having trouble with the kids, and that's the cause. Well, even when we evaluate these people, probably as many as half of them don't have any very easily definable heart disease. But remember we said that even in the people with lone atrial fibrillation, we had some scarring. Well, the scarring seems to progress and become more predominant as the atrial fibrillation goes on. And in fact, atrial fibrillation by itself can cause some scarring in the heart. So we have the fibrosis level that's least in lone atrial fibrillation. It accumulates in paroxysmal atrial fibrillation, and now it becomes more diffuse and more important in persistent atrial fibrillation in the next stage, in permanent atrial fibrillation, when a person just develops the atrial fibrillation and it continues and continues and continues. Well, in permanent atrial fibrillation, and we define permanent, the terms are peculiar, because in permanent atrial fibrillation, it's not that it necessarily lasts forever. It's just that you've failed either medical or cardioversion therapy. You just don't seem to get back to normal, or the doctor says, hey, it's not worth our effort. In that case, it's defined as permanent. Now, you can't tell the difference as far as the symptoms are concerned, but you certainly can tell the difference in response to therapy, as we'll talk about. If you have relatively minimal disease, lone atrial fibrillation, paroxysmal atrial fibrillation seems to respond better to treatment than it does if you have persistent or permanent atrial fibrillation. And as a matter of fact, in people with permanent atrial fibrillation, now we find that the accumulated disease, the burden of disease, the heart-related burden, increases, so that in most of these people, we're going to find some evidence of structural heart disease. Now, when a person develops atrial fibrillation for the first time and sees the doctor, and the doctor makes the diagnosis, it's basically impossible to determine what the subsequent pattern is going to be, how long the condition is going to last, how many recurrences a person is going to have. That can only be decided as we look back. Now, some people don't like the categorization that we just mentioned. Most people do. But some people don't like to talk about lone atrial fibrillation that I said is sort of on the way out. We don't use that as much. We now call it paroxysmal atrial fibrillation, and then persistent and permanent atrial fibrillation. Some people say, let's call it, we have the initial diagnosis, the first time that the doctor is able to make the diagnosis, or we have recurrent disease. In other words, this is your second or third or fourth or fifth episode. Now, some people like to talk about chronic atrial fibrillation, but we don't even know what that means, so that term is sort of out the wayside. Now, it's important to realize that even though atrial fibrillation tends to be a relatively easy diagnosis to make, well, we also know that there are some other conditions that can mimic it as far as symptoms are concerned and as far as the electrocardiogram is concerned. So it's not the easiest diagnosis in the world until we get sort of a lot of experience. Now, if we're going to divide the patients with atrial fibrillation, we said that there are up to 5 million people in the United States right now with the condition, well, we can say that paroxysmal disease, the disease that sort of comes and goes, oftentimes dissolves spontaneously within less than 24 hours, certainly less than 7 days, that occurs in about a quarter of the people. Persistent disease, another quarter of the people, and unfortunately the most difficult type to treat, the permanent variety, occurs in about 50% or half of all of the people with atrial fibrillation. Now we know it isn't that the symptoms are different. We know the likelihood of stroke and the likelihood of getting back to normal tends to be different. And certainly as we get accumulated heart disease over a period of time, as we get older, well, then any little abnormality of the heart function is severe enough to cause more problems, to cause more symptoms, and to be more confining. And we know that over a period of time, for instance, over a period of a year, we go from paroxysmal to permanent disease, probably about 1 in 10 people or thereabout. And we know that maybe in a period of 4 or 5 years, about a quarter of the people who have the initial manifestations, the paroxysmal atrial fibrillation, are going to progress onward. So we know it's a chronically progressive disease, a disease associated with more age, more high blood pressure, more coronary artery disease, more congestive heart failure, and then, of course, more other problems like the alcohol and the obstructive sleep apnea and the chronic obstructive lung disease. All of those increase the incidence, of course. So there's a natural progression of the disease. And it's also very important to realize the longer you suffer from atrial fibrillation, the longer it lasts, the more likely you are to have more atrial fibrillation. So it seems that just like some people, when you get an allergy, you start to scratch at your skin, and the more you scratch, the more it itches, so the more you scratch. Well, the same thing with atrial fibrillation. The longer it lasts, the longer it's going to last, the more often it's going to recur, the less likely it is to respond to therapy. And by the same token, normal sinus rhythm, the heart beating normally, well, that's going to beget more normalcy. So the longer we can keep you having a normal rhythm, the longer you're going to stay that way. The longer it takes to get into that normal rhythm, well, the longer it's going to take to get out of it. And by the same token, we know there are certain risk factors. So there are variables. And the variables occur differently in different kinds of people, in different individuals. So we know that if you have an enlarged left atrium, if the left top part of the heart, the left atrium, happens to be enlarged, well, we know that that's going to predispose to atrial fibrillation the older you get. If you have valve disease, if you have heart failure, if you have high blood pressure, if you have chronic obstructive lung disease, all of that increases the risk. So if we're looking at people who might be more prone to develop congestive heart failure, all of those conditions that we talked about are very important, and they also impact on the likelihood of side effects from the medicine and the likelihood that the medicines are even going to be of any benefit whatsoever. But in addition, we have something known as HATCH, H-A-T-C-H, just an acronym, and that stands for heart failure, age, previous either stroke or TIA, chronic obstructive lung disease, and hypertension. Those increase the incidence of atrial fibrillation. And so too does genetics. Now, it's very important to talk about genetics because it seems that those people who have the high blood pressure, who have the coronary disease, who have the congestive heart failure, maybe the reason that those individuals with atrial fibrillation develop the atrial fibrillation is because of a genetic diathesis, a genetic background, a genetic proclivity, a genetic tendency to develop atrial fibrillation. And it seems that those people who have this genetic tendency that's extraordinarily common seem to have a greater risk. Now, what do we know about the hereditary component to atrial fibrillation? We know that it's very important. We know that it was first detected only in 1943 in China, where it was found that in some families there seemed to be a dominant pattern that caused individuals to have an increased incidence of atrial fibrillation. And as a matter of fact, if a primary relative has atrial fibrillation, your likelihood is probably 700 to 800% greater than an unaffected individual. And as a matter of fact, if you have a brother who has the condition and you happen to be a boy, a man, your likelihood of suffering from atrial fibrillation may well be as much as 70-fold greater. If you're a woman, you have a sibling with atrial fibrillation, it might be as high as 30-fold greater. And that's even in people who have normal hearts, apparently, and certainly in people who have structural heart-related disease. So it seems like a common underpinning for atrial fibrillation has to do with the genetic tendency. Now, studies have been done here in the United States at Framingham. They've been done in Iceland, where they do a lot of studies on genetics. And it seems that overall, it at least doubles the risk of having atrial fibrillation if you have the gene in your family. Now, the gene itself was first discovered in 2003, and now we know that it's not just one gene, it's multiple genes. Originally, as I said, it was detected in the Chinese population, and it tends to occur in people who are otherwise relatively young, people who might not even have any other kind of structural heart abnormality. And we know the genes control the inflow and the outflow of certain kind of ions from the heart muscle cells. And that's very important because that controls the contractility, that controls the depolarization, that controls the genesis of the electrical impulse that spreads from one cell to another. Well, what kind of ions are we talking about? Are we talking about something esoteric? No, we're actually not. We're talking about calcium, we're talking about sodium, we're talking about potassium, and these substances, these are the ions that go in and out of the cells that make the cells either prone to beat normally or prone to beat abnormally. And it seems there are a variety of genes that affect the ability of the cells to either push in or push out the different kind of ions. And we call those channels. So we have calcium channels, we have sodium channels, we have potassium channels. And depending on the particular genetic abnormality, and there are lots of them, we can either have a gain in function or a loss in function, so we can have either too much getting in or too much getting out. And when we have those kind of conditions, then we seem to set the stage for atrial fibrillation. And we know that the pores that control the ability of those chemicals, those ions, to get in and out are extraordinarily important. And not only are they important, but now we know that in addition to that, we have certain kind of proteins. And we call these proteins connexins. And the connexins are proteins where one muscle cell sits right next to and butts on another muscle cell. Well, the junction of those two muscle cells are some kind of a protein called a connexin. And depending on the abnormality of the connexins, we can find that there's abnormality that spreads from one cell to another extraordinarily rapidly. And it seems that these kinds of genetic abnormalities are what we call somatic in some cases, kind of like cancer, where if we study the blood cells, we don't find the abnormalities in the blood cells. We only find the abnormalities in the cancer cells. Well, the same thing. If we study the blood cells in people with atrial fibrillation, we don't find any abnormality, but we do find those abnormalities in the heart cells. So it seems that we have, overall, the story is, a genetic predisposition to atrial fibrillation that's going to be triggered by something. So overwhelmingly, it's triggered by something. And the something might be high blood pressure, might be some inflammation, might be that the heart doesn't function well because the muscle is too thick in the ventricle because you've had high blood pressure, maybe because you had a heart attack, maybe because you have congestive heart failure. And that leads to some abnormality in the heart. So a genetic proclivity, a genetic tendency, added to some other kind of an abnormality, and now all of a sudden, we have the underpinnings for atrial fibrillation. Now, in addition to all of that, there are a variety of other biochemical factors that we'll sort of mention as we go along. But let's say let's say there's a question of, do you have atrial fibrillation? What should we do? Well, for the overwhelming majority of people, it's not an emergent problem. We have a little bit of time to go and make the diagnosis. After all, we said the condition oftentimes is going to go away by itself. So what do we like to do? Well, we like to make sure you don't have too much of an anemia, because people who have anemia can be at considerably increased risk for atrial fibrillation. We also like to make sure you don't have an infection. So we can do a simple blood test, check your white blood cells, check your red blood cells. We can do a chest x-ray, make sure you don't have pneumonia, make sure you don't have vascular congestion. See if you have chronic obstructive lung disease. We also want to do some tests, simple tests, also just blood tests to check your metabolism. So we do some tests to check, make sure your kidneys are appropriately functioning, because remember we said that atrial fibrillation leads to kidney problems lead to atrial fibrillation. Same with diabetes, goes both ways. Diabetes leads to atrial fibrillation. Atrial fibrillation can impact on a person's metabolism, and through some abnormalities in the metabolism can alter the likelihood of diabetes in some people. We know that heart-related disease is important. We know that endocrine factors are important, so we check to see what your thyroid level happens to be. We know that the heart has certain abnormalities that predispose to atrial fibrillation. So we can do some simple tests. We can do an echocardiogram. We can do some simple stress tests, electrocardiogram. By doing that, we can find out what size, what shape, what the chamber size is. Oh, that's relatively simple. We also can do some simple tests to find out how the atrial fibrillation is affecting you, affecting your function, ability to function. So we can see if you can walk for a period of about 6 minutes. That seems to be a standard test. Or we can do an exercise test, or we can do some fancy studies that for the overwhelming majority of people are not necessary. Now, we said that thyroid hormone is important, and thyroid hormone is important for a variety of reasons. One is because it stimulates the cells to fire more quickly, shortens what we call the refractory period, the period that they require to rest in between beats. We know that the thyroid hormone is going to act directly on the muscle cells, and we know that the thyroid hormone is extraordinarily important. Now, not all people who have hyperthyroidism are going to have symptoms. So we still have to do the test because we have a high frequency of what we call covert hyperthyroidism or occult hyperthyroidism. Hyperthyroidism that's not present as far as symptoms are concerned. It's present as far as the concentration of the hormone in your blood is concerned. And that can direct your heart function. And also we have to check to see if you have high blood pressure. Obviously, that's a relatively simple test. Well, we know that high blood pressure is going to make the ventricles more difficult, more thick, more stiff. And as the ventricles become stiffer, we know that the atria have to close down or contract more forcefully. That's going to lead to some enlargement. And left atrial enlargement is a very frequent cause associated with atrial fibrillation from high blood pressure. Then also we have to look at the age of the heart, the mass, the diameter of the heart. All those things are very important. And congestive heart failure, we said, is extremely important as a cause of atrial fibrillation. So a lot of people don't even know they have heart failure. Heart failure doesn't mean your heart isn't working. Heart failure means it's just not working as well as it should. It's not producing enough oxygenated blood to meet the mass or meet the necessity of the rest of the body. Now we know people who have mild or moderate heart failure obviously can be functioning perfectly normally in society. Well, those people have about a 10 to 20% risk of having atrial fibrillation, but as you develop more and more heart failure, and as you become more incapacitated, as your legs begin to swell, as you can't lie down flat because the fluid seems to build up in your lungs overnight because you get up too many times at night to tinkle, or maybe because you can't lie flat because you become short of breath. Well, in those people, or people who have decompensated heart failure, and we're talking about another 5 million people with heart failure in the United States, we find that about 50% of them are going to develop atrial fibrillation. Well, we know that's obviously a major issue. And people who have heart attacks, well, if the heart doesn't work well, that's going to significantly compromise the ability of the top part of the heart to function if the bottom part isn't functioning. So we know that people who have heart attacks or people who have unstable angina are at considerably higher risk for developing the problem, and so too are those people who have other major cardiovascular function. Now we know that atrial fibrillation is associated with a decrease in the function of the left ventricle, the bottom part of the heart. And that's very important because remember, if the bottom part isn't doing what it's supposed to do, the top part is going to suffer some consequence. And the most common consequence is going to be atrial fibrillation. And it's important to realize that this whole story becomes even more common as we grow older. If we look at people who have what's known as the sick sinus syndrome, and the sinus is that part that normally generates the electrical impulses, and in this case, we assume that it does, but we're not exactly sure. We know that those people who have sick sinus syndrome, if they happen to be older, as they develop atrial fibrillation, well, their heart rate probably isn't going to be increased considerably because they also have an abnormality of that junction of the door in between the top part and the bottom part of the heart, part that we call the atrioventricular junction. Well, if those people have a relatively normal heart rate when they have atrial fibrillation, and now all of a sudden we said that the condition can come and go, so you don't have to have atrial fibrillation permanently, but as it stops, now all of a sudden the heart rate may fall precipitously, and these seniors, typically seniors, can suffer from loss of consciousness. They can develop what we call pre-syncopal episodes. They can fall, they can break their hip. And this is not uncommon in older institutionalized people, people who are living in nursing homes. And this might occur in as many as 25% over a period of about 10 years. So we know that's extremely common. Now, we said that if we look at new onset atrial fibrillation, we're going to find that there are certain kind of underlying factors that keep repeating themselves. And they are high blood pressure, and now we've mentioned obesity because of the fat, and the fat can infiltrate into the heart directly, so the heavier you are, the fatter you are, the greater your risk for developing atrial fibrillation and greater your risk for diabetes. And now we know people who smoke cigarettes, high incidence of the problem. So what is the underlying cause? Well, we said we have the genes and we have the high blood pressure and all of those factors, but there probably is something in addition to all of that. And the something in addition to that has to do, apparently, with some inflammatory elements that are formed inside the heart and some neuroendocrine substances. So we have an abnormality of the renin-angiotensin system that comes from the kidney system that's important in regulating blood pressure. That seems to be a factor. And as a matter of fact, that's important to realize because that suggests some kind of therapy in addition to the standard therapies that we have right now. And then we know that we need a trigger. We need something that triggers the whole condition to begin. And then we said the condition occurs in adults, doesn't occur in kids. So we need an appropriately primed substrate. Substrate is the atrium that's had the damage, maybe the fibrosis as a result of the increased size because of the abnormality due to high blood pressure. And then we have to have the activation of the nervous system. Remember we said the autonomic nervous system, the system that has the production of adrenaline or something known as the vagus nerve that is the counterpoint. And we know that that's very important as far as the condition is concerned. So now we have activation of all of these systems and all of that together. So that leads to the particular problem that we're talking about. So it's not a simple condition. It's not just simply that there's too much activity in the top part of the heart. And now over a period of time, we've realized that the activity isn't really in the right side of the heart. It's more often in the left side of the heart. And as a matter of fact, we know that it may well have to do with some peculiar mechanism of generation of electrical impulses coming, of all places, out of the area where the pulmonary veins bring oxygenated blood back to the heart. And that is getting to be, and that is one of the major thoughts as far as atrial fibrillation is concerned. Not the only thought, but one of the major thoughts. And that's why sometimes atrial ablation seems to be an appropriate therapy. But getting back just for a moment, before we get to all of those conditions, we said that a collection of fat that stores the triglycerides, develops not just inside the belly to make you fat, make you seem to have a big belly, make you seem to have to get bigger pants, but now we know that some of those fat cells, especially the brown kind of fat cells, can get inside the heart muscle itself. And when they get inside the heart muscle, you have to realize that fat cells are metabolically active, and those metabolically active fat cells are going to make substances, and the substances are going to have to do with oxidation. You hear about the antioxidants. Well, these are the reactive oxygen species that are being formed that cause significant damage to the DNA, to the cells, and all of that seems to lead to more inflammation. So now we said that triggering substance has to act on the substrate. The trigger, something that stimulates the abnormal production of those electrical waves, and now we have them acting on an atria that is appropriately primed. And part of the appropriate priming in many individuals, unfortunately, in too many individuals in our society, is you're just too fat, and as we become fat, those cells are going to get inside the heart, and they're going to produce a variety of substances, and those substances are going to further predispose to developing atrial fibrillation. So if we look at individuals, we can say, well, yeah, you have an increased risk if you're older, certainly if you're man versus woman, if you're fat, if you have high blood pressure, if you're on treatment for high blood pressure, if you have a murmur in your heart, because after all, a murmur tends to indicate some sort of an abnormality, congestive heart failure. Further studies like echocardiograms don't seem to make all that much difference. Well, we know that all of that put together can lead to a susceptible heart that may well develop atrial fibrillation. So when we come back, we're going to discuss the whole role of the pulmonary veins in the development of atrial fibrillation, and not only the pulmonary veins that lead to a form of therapy, a drug therapy, form of therapy with a ablation, but maybe even some surgery to correct the problem. And then what are the symptoms, and how else can we deal with it? And what do we do about the risk of stroke? All that next time. We'll be back. I'm Dr. Ken Landau.